All right. So now we're going to talk about the large volume nebulizers. Ultrasonic nebulizers spend just a few key points on, and I'll just mention centrifugal and spinning discs for completeness. If you remember, your large volume jet nebulizer works under a couple of principles. Venturi principle is what draws the liquid up because of creating a negative lateral wall pressure there. Also can use to entrain air, and that jet then is going to, when the liquid hits it, it's going to make it into an aerosol. Larger particles fall out of suspension with some baffling, and you end up having the aerosol mist continuing on to the patient. The interfaces that we have, again, they have specific purposes. Most patients that are recently extubated will have an aerosol mask that allows for delivery of a moist air or oxygen. The face tent is used for somebody who perhaps can't have something across the nose, perhaps for some nasal surgery or from some maxillary surgery. T-piece is used for someone who has an endotracheal tube, and a trach mask obviously is for somebody who has a tracheotomy opening. So we're not going to worry about the Mistiox. However, you will need to know about the jet nebulizer, whether it's heated or not, how to set up a tandem setup, and then there were some questions on the self-assessments about blending two flows of gas. Those are fair game also for a written evaluation tool that you may see, I don't know, tomorrow. Different ways to heat nebulizers. We talked about having a probe that's immersed into the water, what I refer to as the hot rod. Sometimes there's a base that the nebulizer itself sits on. Sometimes it's got a jacket that wraps around, or there's ones here that have a little heated collar. So all they're doing is having the ability to add extra humidity through heating of either the gas or the nebulizer itself. Remembering that when you heat, you run the risk of creating condensation within the circuitry, and that condensation within the circuitry can create some back pressure. That back pressure is the only reason you would have a air entrainment device developing an FiO2 that's higher than the set value. You'll never see that without any back pressure. Okay? Yes?
Why would we heat nebulizers? I thought with nebulizers we don't add the humidity.
You get a higher output.
Okay.
If the temperature of the water is greater, or the temperature of the air that's being circulated through there is greater, you have a higher capacity to hold more. But that back pressure reduces the forward velocity. As the forward velocity is reduced, the air entrainment is reduced, which then allows for a higher FiO2. The only time you'll have a higher FiO2 than what you have set, because here I have water collecting in my circuitry. Avoid that. Put a drain bag in place at the lowest part of the circuitry, recognizing that if the patient is not higher than the drain bag, you run the risk of them being of the condensate falling into them. Okay. In the home, we typically don't run nebulizers with oxygen. We run them with air. You get an air compressor, hook it up to the air compressor, and then run the flow of air through the circuitry and bleed in some oxygen as needed, and we can analyze it downstream and make sure that we have the proper amount of oxygen being delivered. Use of a Y adapter for a tandem setup where I don't have sufficient flow from one nebulizer, and I want to be able to still use this kind of a technology for humidification purposes. I can tandem two together, and that could be potentially one of your performance evaluations on high flow systems. And by the way, that is the proper spelling for Y adapter, W-Y-E. And if you're using a Briggs adapter, remember you have to have a reservoir on the opposite end, otherwise they'll draw back room air and you won't have your fixed FiO2 that you're desiring. I would never ask you this to calculate how much output it does, but recognize the important part is that these jet nebulizers, even if they're not heated, can end up having a higher volume of humidity than we actually need. We only need 44 milligrams per liter at 37 degrees. These can put out significantly more than that. So you won't have a humidity deficit, basically. Ultrasonic nebulizers. This is chapter 13 in Butler. And this is what the device looks like. Let me just kind of give you a little bit of an overview of what you have. The key element in this is what is called a piezoelectric transducer that converts electrical energy into mechanical energy. Now, this is spelled out in the slide in a second. It vibrates and either hits the water directly or hits through what is called a couplant chamber. In other words, they make this water in a lower chamber vibrate. That then causes this to vibrate, which causes whatever solution is in here to be nebulized. This fan just basically blows that to the patient. This is what one of them look like, and you can see the particle size is within the respirable level, and you can heat it or non-heat it in that process. Okay, let's talk about the guts of this. It's what is known as a piezoelectric transducer. What that means is it takes electrical energy and converts it into mechanical energy, and the mechanical energy is in the form of sound waves. The sound waves vibrate at a specific megacycles per second. I don't care that you know that it's 1.35 because it's not always, but it usually is. And it's electrically powered, so we want to make sure it's properly grounded. Those vibrations are either transmitted directly to what solution you want to have nebulized, or sometimes there's a couplant chamber, a couplant compartment that holds, it's like a little small bowl that holds the medication or solution you want nebulized, and those vibrations bounce against the bottom of the couplet, or the couplant chamber, and then you end up having the medication being broken into small particles in the form of a mist. There's two aspects to this, and I'll talk about them, and I'll show you a picture in a second. One is amplitude, the other is frequency. You probably have never taken a physics class. I'm going to make an assumption. Maybe you have. But sound or wave theory has two components to it. It has actually more than that, but for our purposes it has two. Has the amplitude, which is the height of the wave, how tall the wave is, and it also has frequency, how close the waves individually are to each other. The closer they are together, the more frequent they are. And then the other aspect is the amplitude. We control the amplitude. We control the size of the wave. That size of the wave is going to dictate the output. How much mist, how much fog is created. Okay? Amplitude, output. And again, I don't care that you know the form figuring out all this, but this is basically just showing that we can get even better than a nebulizer as far as the quantity of humidity that we're creating, and again, well in excess of what the body humidity is. As I mentioned, they have a blower in place. That blower is usually compressed air, but it could be hooked up to a oxygen source in some fashion. The higher the flow, the less dense. It makes logical sense, is that if I got too much gas being blown, I'm not going to have as thick of a mist. And these can literally be fogs that you can kind of lose the patient in. It's the best output other than a heated nebulizer or heated humidifier. Where amplitude determines output, frequency determines particle size. The frequency is fixed at the factory, and it's not something we can adjust. But the frequency determines particle size. Okay. So this is what I'm talking about, amplitude, how tall the wave is. The taller the wave, the more the output. Frequency is how close they are together. It's preset, and it determines particle size. So if you see a question asking what does amplitude determine, it's output. Frequency, particle size. So let's go through troubleshooting them. I don't see any aerosol output. I always love this one. Make sure it's plugged in, make sure it's turned on. Duh. This does require electricity to work. Has a fuse, maybe need to check that. Make sure your amplitude control is turned on. Make sure your water level is appropriate. And periodically that transducer does need to be treated and cleaned with a vinegar solution, kind of as an FYI more than anything else. If I only have a little bit of output, again, make sure the water is there. Make sure your amplitude setting is where you want it. Make sure your transducer is clean. And make sure there's not some water in the tubing blocking the output flow. No mist. Make sure that the fan is working. Make sure that there's not water or kinking of the tubing in some process. Make sure the fan's working if you don't have good gas flow. Make sure the water is not in the circuitry. If they need oxygen, we can either leave them on a nasal cannula for the duration of the therapy, or again, you can bleed some oxygen into the tubing in the circuit. Here's an example of that. There's my nebulizer on the left. It's generating this nice mist fog. I can bleed in some oxygen, analyze it, and get a specific concentration. So again, you should be able to distinguish between a humidifier and a jet nebulizer, and now an ultrasonic nebulizer. Lastly, just making a mention of the centrifugal or spinning disc. These are usually used to humidify our entire room. We rarely, if ever, see these in the hospital now because they are lots of particles that are very prone to having bacteria form in them and carried to the person towards the person. All this is a disc that's spinning. As it spins, the centrifugal force draws water up, and then as the water's released, it hits these baffles. Larger particles fall back down. Smaller particles then are allowed to pass out and into the atmosphere. Sometimes we need to induce sputum to get a sputum sample. The ultrasonic nebulizer works very well for this because of the particle size and the denseness of the fog that we end up having. Although you can use the heated high-volume jet nebulizer also. We're going to have in the nebulizer, instead of water, we're going to have hypertonic saline. Remember, hypertonic, it's going to pull water out of the cell into the outside of the respiratory mucosa and hopefully liquefy whatever secretions we have there. Recognize we're doing these sputum inductions often to determine if they have an organism that is growing, and a lot of times that could be TB. So you want to use appropriate personal protection. We try to do it in the morning before meals, have them rinse off their mouth and nose, clear any excess saliva. Monitor the breath sounds because that hypertonic saline can induce bronchospasm in somebody who's got reactive airways. Doesn't take very long to end up usually to get a good cough with expectoration of secretions that we're going to then handle under standard precautions. Just want to make mention of some hazards of aerosol therapy in general. Sounds like somebody needs some little bit of mobilization there, but okay. They can carry pathogens. The particle size of these are large enough that bacterium, which are smaller, can attach themselves to. So you want to do all your normal infection control, like good hand washing, changing equipment, using only sterile solution, and if you need to rinse out a nebulizer, specifically we're talking about medication nebulizers, we're going to use sterile water, obviously not tap water. Some other hazards could be coughing and irritation. Just whatever we're nebulizing can be irritable to certain patients. One of the good things is that it's liquefying secretions. One of the bad things is that liquefied secretions may not be able to be handled by the patient. If they don't have a good cough effort, we could potentially flood them and literally cause some problems. So you want to be able to be prepared to clear the secretions with suctioning or potentially even bronchoscopy. We talked about bronchospasm being a side effect. Sometimes it's the coolness of the aerosol itself. Sometimes just the density of the particles can be enough to trigger a bronchospastic episode. Some medications are more prone because of their irritant nature. We want to monitor the patient and, if necessary, give a bronchodilator. Recognize that a potential hazard of putting high amounts of humidity into a patient is that in certain patients, like those with CHF, for instance, you can end up having fluid overload. Developing a pulmonary burn if the heated system is not properly monitored for temperature. Any overheating of that water source or medication source can promote injury and certainly can be very uncomfortable. Nebulizers, especially large volume nebulizers, are noisy, especially at lower FiO2s. We would never use one in the NICU, for instance, because of the amount of noise that they create. We're going to use, if we are using an oxy hood, we're going to use a heated passover. And lastly, us. Things that could be bad things that can happen to us. We talked about things like Mycobacterium tuberculosis. Certain medications, pentamidine is one that's an anti-something. We're not even sure what the organism is. We, for years, thought it was a protozoan. We're not entirely sure, but Pneumocystis jirovecii is the organism, and it's found in immunocompromised patients, like patients who are transplant patients or patients who have HIV. And pentamidine is the medication that we use. Whenever it's delivered, we have to have a system where the patient's exhaled gas is not allowed to go to the atmosphere because it could be very harmful for us. Ribavirin is a drug we don't use that much anymore, although occasionally it is there. It's used to treat respiratory syncytial virus, which is what causes RSV causes bronchiolitis rather in infants. And there are antibiotics. Toby, I think you guys learned about. Colistin's another one, that if you're nebulizing them, if you're allergic to that medication, it could be very dangerous to you. So always want to use proper precautions, prevent cross-contaminations. There's specialized masks, like the N95 mask that we use for suspected TB. You can also scavenge it, so whatever exhaled gas is not allowed to get to the atmosphere, it's diverted into the suction system. And then using isolation rooms with proper air exchanges, as well as a booth or a stall for sputum induction. And this is kind of Egan's little algorithm for determining the proper humidifier for a specific patient. I don't expect you to memorize that, but recognize there's stuff out there to help. And we can just see that each of the devices we're going to have is going to have a little bit different amount of percent of body humidity, to the extent that a heated aerosol can actually create an excess of what the body's needs are, so that you end up having an absolute humidity that is greater than the body humidity. And there's some mini clinies and some critical thinking questions, but I think I'll leave it there. Yepper.